All right. So yeah, we actually are getting into the more interesting aspect of medication and principles of pharmacology. So talking about the physiology of pharmacology. The process of medication or chemical following administration is as follows. So we have absorption, we have distribution, biotransformation, and elimination. Pharmacokinetics is the action of the body on a medication. So when a medication binds with a receptor site, one of the four actions will occur. We have channels permitting the passage of ions in a cell wall that will be open or closed. A biochemical messenger becomes activated, initiating other chemical reactions within the cell. A normal cell function is prevented, or a normal or abnormal function of the cell begins, something that it's not typically used for. So medications are exogenous chemicals. Exposure to chemicals in the environment can cause effects similar to those of medications, including adverse effects. So development to reach and bind with particular receptor sites of target cells. There's newer medications that target only specific receptor sites in an attempt to minimize adverse effects. And then many older medications affect cells and tissues totally unrelated to the condition being treated, causing adverse effects. Two types of medications are chemically directly affected, that chemically affect cellular activity by binding to the receptor sites. We have agonists and then we have antagonists. The agonist is doing something, the antagonist is keeping something from doing something. So this figure shows how chemical binds to receptor sites and causes block actions. So you have your receptor sites and then you have your natural chemical, something that's happening. This is a normal system in the body. Now we have an agonist drug. The agonist drug comes, binds with the receptor site. The natural chemical can't do whatever it was supposed to be doing to enhance, in this case, cellular activity. One example of this, you could replace, let's say somebody's doing drugs. They're taking fentanyl or something else. This is the fentanyl. It's hitting your receptor site. It's giving you a high. Not only is it giving you a high, it's telling your body to do something such as slow your respiration down. Now you're dying. Us, as the paramedics, would come in with naloxone or Narcan. Now we've introduced this agonist that comes and stops Narcan from hitting these receptor sites. This then wakes that person up, they lose their high, they come back to life, they can breathe. I saw this literally 2 weeks ago. And then you have their antagonist drug. Oh, well yeah, here we go. So it comes in and it plugs and prevents this from happening. Same concept. Agonist medication. So factors that determine the concentration of a medication present at the target cell site is dose, route, other factors. Affinity is the ability of a medication to bind with a particular receptor site. So medication concentration and affinity determine the number of receptor sites bound by that medication. Agonist medication binds with receptor sites and initiates the altering of the cell action. Everything I just talked about. The threshold level is the level at which initiation or alteration of cellular activity begins. Increasing concentrations of medication cause an increase of effects until all receptor sites have become occupied. Maximum capacity of the cell is reached. You can only do so much with so much medication. If you take enough Narcan, eventually you're just pissing it like vitamin C. Potency. The concentration of medication is required to initiate a cellular response. As the potency increases, the concentration or dose required decreases. Limit of change in activity. So once all cellular receptor sites become bound with agonist medications, no further change in the activity is possible. Further dosages will not cause additional cellular action. And the dose response curve illustrates the relationship of medicine concentration and efficacy relative to the dose. So as we're increasing our dosage on the timeline, you take enough of the medicine, then the increasing effect goes up. But eventually, all of the receptor sites are hit, and we can't get any more of an effect once we're at the max. And then this is the threshold, so you're taking enough medicine until eventually it kicks and starts doing stuff. The half-life isn't killing it off. Now it's actually hitting the cells. Antagonist medications. So they bind with the receptors to prevent any natural causing happenstance of the body. So these can be used to inhibit normal cellular activation by naturally occurring agonists in chemicals within the body. So we want to treat the harmful agonist effects of exogenous medications or chemicals. These might be competitive antagonists, temporarily binds with the cellular receptor sites, displacing agonist chemicals. Efficacy is directly related to the antagonist concentration near the receptor sites. Efficacy is related to the antagonist affinity compared to the affinity of the agonist chemicals present. Say that 5 times fast. Non-competitive agonists. Permanently binds with the receptor sites and prevents activation by the agonist chemicals. These have effects that continue until the new receptor sites or cells are created. Cannot be overcome or increased doses of agonist chemicals. So this would be the Narcan I was talking about. Partial agonist chemicals bind to the receptor site but do not initiate as much cellular activity or changes as do the other agonists. Lower the efficacy of other agonist chemicals to present at the cells. Then there's alternative mechanism of drug action. So it alters the cell tissue, the organ, the system function without directly interacting with the receptors on the individual cell. Engineered to target other sites throughout the body, so they're microorganisms, lipids, waters, exogenous toxic substances. Targeting of specific substances present in the cell of either bacteria or fungi. So you have antifungals, antibiotics, chelating agents. So these bind with heavy metals, could be lead, could be mercury, arsenic, and this could also create a compound that can be eliminated, such as sodium bicarbonate. We use that in a lot of heart attacks instances because it's going to stop the cell death that's producing these nasty like emboluses and toxic waste products that travel through the brain, through the vein and get to the heart. So sodium bicarbonate is going to keep that from happening. Creates compounds that can also be eliminated. So we have breakdown after administration producing bicarbonate ions. So this binds with excessive hydrogen ions, raises the pH, decreases the acidity of various body fluids. Diuretics, we're going to create osmotic changes. After the distribution of fluids and electrolytes, we may alter the distribution and fluid of electrolytes and then draw excess water away from certain body tissues while enhancing excretion of urine. Target water in the body can alter distribution of various water fluids. So electrolyte-based medications, I want to say lactate ringers is one of these. Changes the concentration and distribution of ions in the cells and fluids throughout the body, which affects the ability of various cells to function. Factors affecting response to medication. This could include choice of medication, dose, route, timing, manner of administration, and monitoring. Factors that are in how medication affects a patient due to weight-based dosing. So you could have age, that's going to matter. Water, lipid, fat, protein are the 3 primary types of body substances that medication distributes through. And then with water-soluble medication, medications that are higher weight-based dosages must be administered to infants, to adults, to elderly people. And then if it's fat, then it's going to be through lipid-soluble medications, require higher weight-based doses in elderly people. So whenever we're treating pediatric or elderly patients, we want to consider careful titration of medication rather than administering on a weight-based distribution. So cytochrome P40 system affects medication metabolism. We'll call it metabolism in the liver. It works differently than different types of medication. It's extremely variable on infants and children, and has functional decline in elderly people. Decline in the liver kidney function provides a decrease in dosage of many medications. Patients with extreme in age, at extremes of age, are disproportionately prone to paradoxical medication reactions. Patients that experience clinical effects opposite to those of the intended side effects of the medication. Thank you. All right, let's see if we can find some better information.